Thank you so much, sir, and thank you for having me in this course. I'll try to be as brief as possible in the interest of time. The talk is about the basic ray tracing and what do we understand by what ray tracing means and what are the advantages that this instrument gives us. So the eye trace is basically a 5-in-1 technology. It's a wavefront aberrometer. It does corneal topography, which is Placido based. It is an auto-refractor, an auto-keratometer, as well as a pupillometer. Now, the principle of ray tracing is that it uses near-infrared beams at 655 nanometers. 64 beams are projected sequentially 4 times at different locations on the retina for a total of 256 spots. It's important that these beams are projected one after the other and not simultaneously, and each of them is then individualized and analyzed individually so that there is no confusion and it can be imaged even in highly aberrated corneas. The retinal positions of all these rays are mapped, forming a retinal spot diagram, and the wavefront is then reconstructed by plotting the emergent rays. Before we go on to seeing any of the other information, what we should see is the verification display to see whether the data is reliable or not. So this helps to verify the integrity of the data. And if we see on the top left hand of the screen, we see it's mentioned as 0.1. If greater than 10 points are shown as rejected, it implies that the reliability is questionable and probably the scan should be taken again. The other thing about the retinal spot diagram is that it should not have large areas of discontinuity. In a optically perfect system, all these spots would focus on the macula and hence it would be in a very close cluster. But most eyes have some degree of aberration. So the image on the left shows the retinal spot diagram of an eye with minimal aberrations, but it's still continuous. On the left, we see the retinal spot diagram of a highly aberrated eye, for example, a patient with advanced keratoconus. But we can see that there are no rejected points. So although it's aberrated, but it's reliable data, and perhaps the eye trace is the only machine which can take up data in such aberrated eyes. Then coming to the next, this is the Chang analysis, a screen which all of us use frequently. It can give us at a quick glance a very quick idea of whether a person should be going in for a premium IOL or a toric IOL, and what are the main sources of aberration apart from a lot of other information. I'll take up each of these components one by one. So for example, one part on the left hand side, we have the aberrations or the which are provided by the total eye. We have the internal and the corneal. And then the corneal aberrations are separated from the total eye aberrations, and that gives us the remaining internal aberrations, which are mainly derived from the lens. And perhaps this ability to separate the corneal from the internal aberrations is what makes the eye trace most useful. For example, in this eye, we see that the internal aberrations mirror the total aberrations, and the corneal aberrations at the lower left hand of the screen are minimal. So that's a general rule in anything. If you see bars, too many bars are bad, no bars are good. Basically, what this means is if you see too many bars, that means there are too many aberrations, and if there are less bars, there are less aberrations. And in this case, since the aberrations are arising mainly from the internal, mainly from the lens, and mimicking, reflecting that of the total eye, so this pathology is, we can say clearly, it's predominantly a lenticular pathology. Digressing from the Chang analysis, just to give this a bit of a clinical perspective. So this image that I have shown, the predominantly lenticular aberrations, this was a patient with bilateral anterior lenticonus, as can be seen clinically as well as on the ASOCT. And he had a preoperative best corrected visual acuity of 636, probably because of the extreme degree of aberrations and the high refractive error. And once we did surgery phaco for the left eye, we can see that the total and the internal aberrations have reduced because of removal of the crystalline lens. The cornea is showing a few bars because the left eye had some astigmatism, which is residual, but otherwise the visual acuity also improved from 6 to 6, and the eye trace tells us that the internal aberrations have gone. The other very useful display, which is an extremely useful tool to demonstrate to the patient what is the source of his problem, would be this visual quality analysis. For example, the panel at the top shows us what the quality of this patient's vision was before surgery, and we can see that most of the aberrations were arising from the internal. And post-surgery, the aberrations have reduced to the minimum, and the quality of vision as well as the quality has improved markedly. So coming back to the Chang analysis, the other information that gives us, the one pointed at the bottom of the screen, is that while using the AICR's calculator, the value of the atlas rings is sometimes a data point which is to be fed in. And this is given right at the bottom of the screen. And from here, we can acquire these values. The second is the effective refractive power. Sometimes in cases of post-LASIK and post-refractive surgery eyes, this is the value we have to feed into the calculating eyes. And this again is given here. The corneal spherical aberrations, the most important thing for deciding a multifocal IOL is that we don't need a multifocal cornea. The cornea should not be multifocal. And so if we have the corneal aberrations which are more than plus 0.3, then it's best to avoid a premium IOL, which I'm sure will be talked about later by Professor Tityal and the other speakers. Angle alpha is the other parameter which is seen on the Chang analysis. I'm just touching upon these briefly. Now, angle alpha is basically a metric of the how well the bag IOL will center in the eye. There's another screen in addition to the Chang analysis where you have the angle alpha and kappa are demonstrated. The angle alpha is basically the angle between the visual axis and the center of the limbus or the geometric axis. And this is where the IOL will center. And this is what is important in IOL planning, because if the angle, it's a confidence of a metric of the confidence of putting in multifocal IOLs. If the angle alpha is more than 0.5, it's a large angle. It gives us an idea that the IOL, the center of the IOL will not be at this in line with the line of the visual axis, and the patient may have some symptoms. And if angle alpha is more than 0.5, premium IOLs should usually be avoided, although this limit can be stretched a little bit with the newer IOLs. So just to summarize in brief, the process of planning from a premium IOL using trace, if we have a high angle alpha, we would consider a monofocal option, probably not going for a multifocal. Next, we see if the patient has the corneal aberrations, whether the corneal aberrations are low or high. If the corneal aberrations are high, again consider a monofocal option. If they are low, then we analyze we consider whether this patient is a candidate for a toric IOL. If yes, we can use the iTrace toric planner. And if not, then we can consider the multifocal or a premium IOL. So that was just in brief a little bit about the utility which the iTrace can give us. Thank you very much.